and thank you all for taking the time to join us today for the IFA's weekly Global Cafe. I have the distinct pleasure this morning of being your moderator and in being in conversation with Dr. Mary Tinetti. Dr. Tinetti is the Gladys Phillips Crowfoot Professor of Medicine and Public Health and Emeritus Chief of Geriatrics at the Yale School of Medicine. Dr. Tinetti is currently at the forefront of a nationwide effort to develop and test an approach to healthcare that aligns clinical care and decision-making with specific priorities of older adults with multiple health problems. This involves assisting patients in identifying their most important health goals and teaching clinicians to translate these goals into care decisions. She is also evaluating how feasible this approach is for clinical care and its effect on patient outcomes. Her research also addresses the net benefits and harms of commonly used treatments for older adults in the face of multiple health conditions. In her previous research, Dr. Tinetti and her team have also helped identify the causes, consequence, and preventative strategies for reducing the occurrence of fall injuries in older adults and translated these findings into clinical and public health practice. Dr. Tinetti has over 250 publications, excuse me, and is a frequent speaker on the care of older adults and has received numerous awards for her work and research. She is also a member of the National Academy of Medicine and is a MacArthur Foundation Fellow, all in addition to providing clinical care for her patients and older adults in Yale New Haven Health. Before we start to unpack some of your current research priorities, Dr. Tinetti, I'm curious to know what inspired you to focus on geriatrics and how your experiences throughout your career have helped inform your research priorities.
Yeah, thank you. And thank you for inviting me to do this morning or this afternoon or this evening, wherever you might be. So when I first decided to do medicine, I wasn't quite sure what I wanted to do, as most people are when they get started. When I was doing my training, most of my colleagues, my contemporaries, were very interested in sort of acute care, the emergency room and emergencies that you could cure people very quickly. But I got really enamored with more the people with more complex issues, more chronic conditions. That sort of intrigued me. It was more problem solving involved, and that sort of drew me to, when I was getting started, geriatrics was a new field. So the idea of being part of a new field and the complexity was what really drew me to the field. The other thing I really like about geriatrics is that you cannot address the care needs of older adults without considering everything in their life. There's not the artificial barrier between these are their health problems and these are the life context. It's all meshed in together, and I found that very appealing. And I really wanted to be part of a field that really figured out how to help older people.
That's great. Thanks so much. It's sometimes crazy to think that geriatrics is in some ways a new field of medicine. If you think within our lifetime, it's quite mind-boggling. So a major theme in your current work priorities, Dr. Tinetti, is understanding patient priorities. I'm wondering if you can kind of elaborate on what you mean by patient priorities in the context of geriatric care.
Sure. So as most of you, I'm sure, know, is that healthcare has arisen by being very condition specific. So the structure of our healthcare is around specific conditions. As health professionals, whether we're physicians, nurses, social workers, therapists, we learn how to treat individual conditions, and that's where the evidence lies. And that's, at least in our country, and I think most of the world, that's how healthcare gets paid for. So, but as people age, they accumulate different combinations of conditions. So some people might have, heart disease and lung disease and depression. Another person might have severe arthritis, and diabetes, but complicated by some social vulnerabilities. And more and more that I was taking care of older adults, I was realizing that trying to treat each individual disease, it just became very complicated. I wasn't sure whether I was doing more harm than good, and my colleagues were feeling the same way. People were saying that they spent their entire life going to all their different clinicians that were doing more and more testing, giving them more and more medications. And so it get more realizing that our current approach to disease siloed care was not working very well and was really particularly harmful. And the other thing that one of my colleagues, Dr. Terry Freed, showed when she was looking at older adults and asking them, they really varied. when people are young and have a single disease, they almost always want the same outcome. If they have appendicitis, they want their appendix removed so they don't have pain. If they broke their arm, they want it fixed so it gets better. If they have diabetes, they want that under control because they're going to have 50 years of the adverse effects of diabetes. But as you accumulate more conditions and more life variability, you're faced with more trade-offs, and people vary. Some people might want to live as long as possible, even if they're not as comfortable or functional. And for other people, function or comfort might be their priority. So if the care we currently provide is potentially not beneficial, potentially harmful and burdensome, and people vary what it matters most to them, it became really clear that we have to start by identifying each individual's health priorities, what matters most to them about their health and their health care, and do it in a way that can inform decision making. So it's not enough to say, well, what's most important to you? What matters most to you? What's a good day look like you? We have to take those and translate those sort of health values and life values into very specific and actionable and realistic health outcome goals, so that everybody who works with that individual can align their care with those priorities. So their priorities are the specific and actionable and realistic health outcome goals each individual wants from their health care. I want to be free enough of pain so that I can garden today, and then my allergies get worse, as based on our earlier conversation. So if I know that that's my priorities, then my cardiologist, my social worker, my physical therapist may know what to do to help me get that care.
Right, Dr. Tinetti, that's super interesting. I feel like some of the underlying, what you're saying is some of the kind of underlying assumptions that we go into with medicine are kind of framed based on the needs of younger people. I'm curious to know whether you've seen any kind of patterns or kind of recurring themes in the common priorities of older adults in your work.
Well, yes and no. I think when I first started doing this, I think the concern that a lot of people, my colleagues, particularly my specialist colleagues, were concerned about, where people were going to be asking for really unrealistic and unachievable things that healthcare couldn't give them. So one of the things that we did found pretty quickly, we've now done this in thousands and thousands of people, the vast majority of people really do identify very practical, very achievable health outcome goals. And frankly, that's part of the process we've developed. We've developed walking people through it so we get to that realistic goal. But that being said, is that people do vary in what matters to them. It sort of, we have this sort of framing of the values, and most of the values that people have in their lives, and this is for younger people as well as older people, it's either the connections, relationships, connections, the meaningful, productive activities. People really want to have meaning in their life, really be productive. That for some people that might be working, for other people it might be volunteering. And autonomy and independence, and finally sort of managing health. So those, almost everybody, no matter how old they are and no matter where they live in the world, those are the sort of things that really drive them in their life. But then translate those into goals. You can put it into sort of general categories. I will say none of them were surprising. I've not been surprised by any of them, and they're, like I said, I think they really are achievable for the most part.
That's great to know, Dr. Tinetti. I'm curious to know how healthcare providers can effectively balance patient priorities with clinical guidelines and evidence-based practice, and do those ever conflict?
Yeah, that's a great question. One of the first things I always remind people is they're called guidelines, they're not called mandates. And although I think sometimes we as clinicians sort of think about them as mandates, because it makes it simple. I mean, I think the reasons guidelines were developed were because there was so much variability and people weren't receiving care that was really helpful. And that's the good thing about them. The bad thing about them is the evidence that underlines the vast majority of these guidelines were done with clinical trials in people who were healthier, had fewer functional limitations, and usually had fewer health conditions. So a lot of the population that we've been working with patient priorities care are those for whom we're not saying that the guidelines don't apply. We're just saying we're not sure. There's a lot of uncertainty. And so if you want to kind of peg older adults, we have about, if you take people, let's say 70 and older, is about probably 30% of that population are those people who have one or two diseases and look very much like the people in the clinical trials, and guidelines are very appropriate for their individual diseases. Then you have about 20% of people with very advanced illness or a single defining dominant condition, very often where advanced illness, where you really focus on that condition and or palliative care. So we're talking about that 50% or 60% or so of people in the middle who are starting to accumulate conditions and functional limitations. So just to remind you of that. So the idea is you don't ignore the guidelines, but they get filtered through the lens of what matters to that individual. And we realize is that very often treating, if you go only by the guidelines, treating their heart disease might make their lung disease worse, or they're treating their depression may make their blood pressure worse, or vice versa. So it's looking at the diseases through the lens, number one, of what matters to that individual, but also number two, to the accumulated effect of all their conditions and their life circumstances. So it's not that we ignore guidelines, but we do them through the lens of what's appropriate for that individual.
Right. Thanks, Dr. Tinetti. I'm curious, in a slight tangent here, but you mentioned kind of the use of clinical trials are often kind of important in the establishment of guidelines. Now, I'm aware that like often older adults are not necessarily included in clinical trials as an age category. How much does that affect the guidelines that get produced, and how much of kind of working with older adults are you having to kind of, again, not throw the guidelines out, so to speak, but how much of kind of a lack of research involvement of older adults makes your work more difficult, or how you have to kind of work around that?
Yeah, no, I think it's a major issue, and that's as I mentioned, it's uncertainty. And I think the gap between the clinical trial evidence and what works for our population is really huge, and it's uncertainty. And you're exactly right. If you even clinical trials that were designed and carried out in older adults. I don't know, people may be familiar with what's called the SPRINT trial, which was a trial a few years ago looking at more tight control for hypertension. And there was a lot of press about showing even in older adults, they have fewer strokes. Actually didn't have fewer strokes. They actually had less heart failure, but with tighter control. But even if you look at that population of the older adults, they tended to have a little less other conditions and less functional disability. So even trials that are meant to enroll more older adults are not necessarily representative of older adults based on functional level, and also underrepresented are people of color and lower socioeconomic status. So the other problem with clinical trials is they tend to be disease specific outcomes.
Right.
An intervention might decrease your risk of a stroke, but in my earlier work, you mentioned falls. And so one of the studies we did at one point was, well, it's still controversial, but most of the evidence suggests that tighter control of blood pressure does result in more frequent falls. It's again, the studies have been inconsistent, but overwhelmingly that seems to be the case. So how do you, if you're somebody who is at risk for falling, but also has hypertension, how do you use the evidence to decide what to do with that individual? So I think so we have to move towards outcomes that are based at the patient level rather than the disease level to really have the evidence to guide our decision making for older adults. So it remains a major problem, the uncertainty.
I'm going to have to leave the fall prevention, even though it's niggling at my brain, and hopefully I can circle back to it later. But I'm curious to know whether there's any kind of specific tools or approaches you've developed or you're aware of that have helped clinicians understand and incorporate kind of patient perspectives and priorities into treatment plans.
Yeah, there's certainly a broad effort to do that. I think people around the world have recognized that it's important to incorporate sort of the patient voice and patients' priorities and preferences into care. It gets very complicated when people go to multiple different clinicians who are all looking, again, we call it sort of looking at different pieces of the elephant. So how to actually operationalize that, I think, has been a problem. But there are certainly tools out there to do that. The one we actually have created, that's what we've actually been working on over the past 7 or 8 years now, is to develop tools that can be incorporated into a practice to help people identify their own particular health priorities. And we've developed a process that takes about 20 to 30 minutes if it's guided by a member of the healthcare team, and any member of the healthcare team can do it, to help people walk through their, as I said, those sort of general values, translate those into very specific health outcome goals, identify from the individual's perspective what they think is most impeding their goals, and then talking about the healthcare they receive that they think is helpful and doable, and that they think is sort of too burdensome or not helpful. We've also, for those people that are interested, have developed a way for people to either walk that through themselves online, or if they have a care partner family member who's able to help them, or it can actually be done in the clinic setting as well. It's at myhealthpriorities.org. And we're just going to be launching a revision of that hopefully in the next couple of weeks. So that tool, I think, is probably the one that we have found that I think is most effective in terms of really getting at those goals that can inform clinical decision making. For people who are interested, we do have a whole implementation toolkit at patientprioritiescare.org to learn more about the tools for practice. And again, these are for all health professionals and for older adults and their care partners as well.
Thanks so much, Dr. Tinetti. I'm curious to know, because it seems like there's kind of, two huge buckets of benefits for me here. There's kind of the bucket that it's like you're getting care that more aligns with your own kind of care priorities, but there's also kind of that feeling of potential like more autonomy in your healthcare decisions.
Yeah.
How much of kind of your work have you kind of focused at all on, the mental health impact of just being able to be a more kind of autonomous being within within the context of healthcare?
Yeah, that's a great question. And certainly as we have been because when we first actually developed this work, and throughout it, we've always had older adults and care partners involved. With our studies, we've tried to measure the effect it has on their sort of sense of autonomy. It's been doing it in a quantitative way has been somewhat difficult. But in our earlier studies, we always had an open-ended question. We asked sort of people what their feelings were about participating, even thinking through their health priorities. And some of our themes that came out of that, I think, have been very interesting and eye-opening. For some people, actually, it was interesting. At the very first, sometimes we're a little suspicious, like, why are you asking me that? I mean, you're my doctor. Aren't you supposed to know this already? But once they sort of get through that initial kind of shock is, wow, nobody's ever asked me that before. I remember quotes from some of our earlier studies. Well, okay, now I get it. I'm by knowing what matters most to me, I'm helping you figure out how to help me. And several people said that they really felt that they understood their health better. They felt that they could be a better partner as a part of that, and care partners as well. I think that was one of the when we've had daughters or sons or wives or husbands listening in on identifying over and over again, wow, Mom, I didn't realize that was what most important to you. That's important for me to know. So I do think, again, although we've been having to focus more on the health outcome goals, there's no question about it that it really does affect people's sort of feeling of autonomy as well.
Thanks, Dr. Tinetti. Got a great question here from Shmuel, who's one of our weekly Global Cafe attenders. You've talked about, and it seems like it's a bit of a paradigm shift that you're talking about and kind of how we approach care. And Shmuel's wondering how, what the role of governments and public health systems are in effectively identifying health priorities and when that kind of trickle up is going to happen potentially from your perspective.
Well, what a great question, Shamil. I wish I knew the answer to that. I'm hoping it's in my lifetime. It's an incredibly heavy lift, right? I mean, if you think about our disease approach to healthcare, I mean, it began in the 1700s when we were first able to look under the microscope and and see organisms that were causing disease. And when we in the 1900s and the early 2000s, when we were able to do X-rays, and so it's taken a long time for us to develop that approach to diseases, and it was quite effective for a very long time. As I mentioned, everything in healthcare, from the training to the payment to the office structure to how hospitalized work, is all based on individual diseases. So I think what I do think is positive is the increased recognition of the limits of that approach to today's population. It worked very well when people basically had acute illnesses that you either died or were cured, or if you had a single disease, chronic disease, where you could live for a period of time, but there wasn't a lot of treatments for it. So I think there's increased recognitions of the problem with it, but how to move the needle, I think, is very difficult. I will say that around the world, there's more and more groups working at it. And I think that's really very positive, including governments. But how to figure out how to make that switch when most healthcare is still provided by specialists gets a little complicated. And I think what's eventually going to make the difference, like unfortunately, for better or worse, is the money. Because I think we're spending more and more, and this is true in all countries. In our country, United States, probably the worst, where we spend more and more for the worse and worse health outcomes. But eventually, I think there's more and more recognition of identifying quality measures that drive healthcare and drive payment that are based at the patient level. I know there's a group here in the United States that's part of the federal government, part of Health and Human Services, the Agency for Healthcare Quality and Improvement, and they're actually working healthcare research and quality, working at developing patient-level care plans, so that and I think that's going to be a very helpful. So I think part of it's going to be a financial decision that we need to move more towards utilization that really gets the outcome that people are. It's going to be partly need to be a technical advance, because once we do that, then we have to make sure that everybody is focusing on the same outcomes, whether you're an orthopedist or a social worker. And so I think all of those things and everything depends upon the other. So it's kind of going to be I think it's going to be a very slow go, but I'm cautiously optimistic that we will get there. Again, maybe not in my lifetime, but maybe in yours.
It takes a long time to turn the battleship, right?
Yes, it does.
So I've got one more question, then we've got a number of questions rolling through the chat, but you've touched on something really important, Dr. Tinetti, this idea of cost. And I think, often when we look at kind of any health intervention, there's that, certainly from a policy perspective, the cost benefit comes into that equation. Now, in order to know cost benefit, you need to be measuring, which often doesn't happen for older adults. We're often either not surveilling or kind of measuring those outcomes. So I'm curious to know how you've been measuring the effectiveness of incorporating patient priorities into care plans.
Yes, and that is definitely a work in progress. Particularly as we're disseminating this work, we're relying on other groups who are doing it to also test the outcomes. So there's only so much that in small studies that you can get the answers that you need. Right from the very beginning, we have been measuring again, patient-based outcomes, what matters to that individual. And in all of our studies, we have found that by asking and acting on what matters to the individual, we have moved the needle on a concept that's called treatment burden. And this is the concept that as chronic conditions accumulate, and there's more and more that we can do in terms of visits and procedures and testing, is that the burden of caring for their conditions becomes almost worse than the effect of their conditions themselves. I mean, it's a modern irony, right? Is that we've gotten to the point that taking care of my conditions is worse than the effect of the conditions. I mean, you can't get more ironic than that. So that's what we've definitely moved the needle on that. People that have gotten care, when they've been asked and act on their care, has gotten better. And with that they've also been able to show an increase in wanted care. And very often that's rehabilitative services and community services, and decrease in unwanted care. And the unwanted care is usually medications that they felt weren't really helping and were causing adverse effects. So we have definitely found change there. There's a measure here in the United States, and I don't know if it's used around the world, that's called Healthy Days at Home. Mm. And it's the days of your life. Number one, you're alive. Number two, you're not in the hospital emergency room or in a nursing facility. And sometimes it'll include days that you're not getting home care, although we don't include that because we think the care at home is what's keeping you at home and functional. And we also included burdensome procedures that take, that are either uncomfortable or takes a day or so to recover, even though in the hospital. And so we have started looking, and that's being used more in studies here, and also hopefully will eventually be a quality measure, because that's why no matter what your diseases are in your life is, that's why you get healthcare, right? Is to spend more of your time doing what you want to do. So this is a practical measure that both shows how much utilization you're getting, but also the effect of that utilization, right? So if this is an intervention that's helping you, you should have fewer interventions and have more days at home doing what you want to do. And so we found a very modest, very modest, and a very small pilot study that there's more days at home. We turned it around and did non-healthy days. So they had fewer non-healthy days in a hospital emergency department, et cetera. Right. The people who receive patient priorities care. But much more of that work has got to be done to really show the effect of this movement from just disease treatment to priorities-based treatment.
Thanks, Dr. Tinetti. I've got lots more questions, but I'm not going to hog the mic anymore. I've got some lovely questions in the chat from our Global Cafe audience. Our good friend Eileen would love some clarification on your comment around fall. So Eileen, are you there and ask your question?
Yes, I won't put on the video. I'm having internet connections. Thank you very much, Dr. Tinetti. You mentioned clarification, and I'm seeking clarification. You meant the risk of fall increases with the treatment for high blood pressure. Is this in relation to the fact that you're lowering it more, and once you get lower blood pressure, you could get dizzy and fall? And the other question is then, have you done any research on the use of blood test ranges for which are normally used for the general population and not for older adults? For instance, thyroid, the TSHs and the T4s. There seems to be some conflict between Europe and North America of what are the ranges for that, depending on age, but we're getting no research on it. Something on that, if you could clarify, it'd be great. Thank you.
Sure. Thank you so much. And thank you for the question. The relationship between blood pressure lowering with medications and falling, and particularly serious injuries such as hip fractures or head injuries, is still an active area of investigation. I'm no longer working in that area, but other people have. And the results have been somewhat conflicting. But that being said, the trend in most of the evidence suggests that once you get between below the blood pressure of, let's say, 140, which used to be the cutoff for normal, now they're moving it more down to 120, is that as you that if you have other risk factors for falling, let's say you have some balance problems to begin with, or you're taking medications for other diseases as well, it does get a point where the lower you are. Yes, it probably, when you stand up, your blood pressure falls even more and you're likely to fall. That is still the supposition. Is that been 100% proven yet? No, it hasn't. So I think that the governments are still kind of, and healthcare organizations are still sort of debating and figuring out what is the sweet spot, what is the level of blood pressure lowering that is sort of gives you the most benefit with the least harm as people get older. But I think I think a good cutoff that we're using in this country is still at the 140 over 80 to 90. But one of the things I would caution is that what we need to do is really test the standing blood pressure. In our country, we still test the blood pressure just sitting. And that doesn't really get the blood pressure that drops when people get up. So probably it's as important to really test the standing blood pressure it is as to decide what is the actual level of blood pressure that there should be. So again, it's one of that trade-off of getting the right blood pressure so you decrease the risk of strokes and heart attacks without increasing fall risk. I think we're still trying to figure that out. In terms of your second question, I have not been involved with any of that work, and so I really don't have, it's an interesting question, but I don't have any information that I can share about blood levels such as TSH. In this country, we don't usually consider treating thyroid until the TSH in our country is around 4 to 5, and the 5 to 7 range still seems to be sort of an iffy range. So, but I'm not. That's not an area that I can comment on from the latest research for sure.
Thanks, Dr. Tinetti, and thanks, Eileen, for your question. I've got a big question here, but a great question from Peter Whitehouse around the future of geriatrics. So, Peter, would you like to come forward and ask your question?
Hi, Mary. Good to see you.
Good to see
my
you.
question relates to other trends in the world that are going to affect healthcare. The climate crisis, I put number one. Intergenerational issues, intergenerational ethics. How do we focus on care of the elderly, but also take care of future elders, namely our children? And finally, technology. There's a lot of space with people thinking that robots and others are going to help elderly. So if you have an hour or two, please do address that question. Thank you.
Well, that's a lot of questions. That's like how are we going to save the world, right? I'll address a few of those. I'll start with the robots and artificial intelligence, which I think is a big area in robots. My concern with aging and artificial intelligence, it's only as good as the information that's available, right? Artificial intelligence doesn't develop new data. They just suck up the data's there and interpret it. And I think a lot of the problem with aging, those data that really matter are not part of the data sets that are getting sucked up by artificial intelligence. I mean, the things we talked about, the fact that people vary in what they want from their healthcare, the function, all of those things. So I think there's a lot of possibilities, but concerns that I have. Your question about climate change, climate change is affecting everything. And I think if we don't deal with climate change, it probably doesn't matter what else we deal with it. I guess I'm probably about as optimistic as I've ever been. I think we're finally at an international level, at least getting with some variability in that it's a big thing. And as you know, climate change is affecting, as always, the two ends of the age spectrum, right? It's the children and the older adults who are like anything. When there's a new problem in health or society, it's the two ends of the spectrum that are most effective. So yeah, I wish I had the answer to that, but it's affecting absolutely everything, and older people particularly. In terms of your question about taking care of older adults now versus older adults that are coming, that's I think that's just a great question. And I'm going to confine it to the healthcare area because that's my area of expertise. I think we're spending way too much health, at least in this country. And I think when I talk to my colleagues around the world, they kind of say the same thing. So much of the healthcare dollars go to older adults. And we can say, well, that's, well, then what we should do is put more money in healthcare in general. So we're not, everybody of all ages are going to get it, but that's kind of not how government works. I think that and this is my honest opinion, and other people can disagree, that I think if we really understood through good research, what are the interventions that give older adults the outcomes they want. And again, as answer my previous question, we didn't see an increase in utilization. We saw a decrease in utilization when you identified people's priorities. So I do think that if we don't want to use that ration word, which is people, at least in this country, really fight against. I think one of the ways to make sure that there are enough money for education for children and healthcare for children is all of those dollars that are going into healthcare would be less if we really focus better on what matters to people. And we're spending more and more to get less and less outcomes.
Thanks very much, Dr. Tinetti, and thank you, Peter, for your question. We've come back to kind of patient priorities, which is great because John Peters has a great question here about the role of kind of religious beliefs. John, would you like to come forward and ask your question?
Yes. As a retired clergy person, and in a culture where we are now have the opportunity to exercise MAID, M-A-I-D, assisted suicide, whatever one wants to call it. To what extent do you see religious beliefs either helping or complicating reaching personal outcome choices?
Yeah, thank you for that. That's a great question and a complicated question to which I certainly don't have a perfect answer, because it is that in terms of religious beliefs, not just about end of life, but about other things in terms of healthcare, it is not uncommon for when we ask people their priorities, for their priorities to be informed by their spiritual and their religious beliefs. And for the most part, that's as long as the outcomes they want are realistic and achievable, I think that that having the religious beliefs be part of what goes into what their goals are makes it more personal and makes it more achievable. When you're talking about end of life, it gets more complicated because then you have that sort of gets if you get to the point where assisted what we call assisted suicide, however you want to, whatever term you want to use, if it's not yet available through the government, it certainly does get more complicated. I do, however, feel that if we started asking people more upstream what really matters most to them, I think that the interventions they will get earlier in the process will make it much less likely that they'll be at a situation where they're so uncomfortable and so unable to care for themselves that they want to actively end their life. So I don't have an answer for when it's, whether or not just asking people's priorities are going to address that issue of sort of religious beliefs. But it also turns around the other direction, because there's a lot of people with their religious beliefs who want more and more life-sustaining treatments, also because of religious reasons. And that I think I find that very consistent with priorities, because we're in an uncertain, because a lot of this is uncertain. So if we're not certain what's really going to help you, and it's your priority to give this a try, to live as long as possible, then I think it's our obligation to offer people that, as long as they're realistic in what the outcomes are going to be for what they achieve. And I'm not sure if that answered your question. It's an important and complicated one that probably minds greater than mine need to come up with a way to address both societal and personal beliefs.
Thanks, Dr. Tinetti, and thanks, John. Again, a very important question. Got a question here from Gareth in the chat around, wanting to have a few examples of kind of the different interventions that older adults would prioritize. Gareth is saying, what are the interventions that older people want? A few examples would be great. I believe in early intervention programs and connecting people to them, but this can be varied and overwhelming for people. So I guess, Dr. Tinetti, the question is, what are some of the interventions that you're seeing in practice for kind of, that align with the priorities of older adults?
Yeah, so that's a good question. Thanks for asking, because I think it helps me to clarify.
Mm-hmm.
So Gareth asked the question that really reflects how we currently practice medicine. Do you want this procedure? I have back pain now, so I went to my physiatrist this week, and he said, well, do you want an injection? And how can I answer, do I want an injection, without knowing what outcome? And that's one of the concerns that I have with healthcare. So the way I sort of thinking about it and how we have built patient priorities care and patient priorities identification is individuals are the experts in the outcomes they want, given their overall health and their life circumstances and their beliefs. And health professionals are the experts in the interventions that are most likely to help them achieve the outcome they most want. So we would never start with, do you want this intervention or don't you want this intervention? We start with, what is the outcome you want? So I'll give an example. Let's say I'm 81 years old, and I have depression, and I have heart failure, so I get short of breath when I walk too much, and I have arthritis, so I have a lot of pain, and I don't have enough money for the transportation I want to visit my family. So I have some financial sort of issues, and I have to live up on the second floor, and the stairs are difficult. So that person's priorities might be, I want to be free enough of pain and less short of breath so that I can do the stairs and get to the bus stop to go to visit my grandchildren. So that's not an atypical health priorities. So it's not necessarily what interventions they may not. So then it's the obligation of the primary care doctor who's taking care of that individual to identify, okay, how can I maximize your medications to help the pain? Or how can I refer you to the physical therapist who is going to work on sort of pain management as well as mobility to be able to do those stairs? If I'm the cardiologist, I might sort of maximize the treatments. I might offer you a procedure that may help cure your heart, one of your heart valves, make it better so that it functions better, so you'll be less short of breath. If I'm the social worker, then I need to figure out, well, can I help you find a living situation where you don't have to do stairs or cover transportation? So that's how it works. You identify the outcome you want, and the people that are working with you help you identify the interventions. So it's not for or against any procedure. For that individual, if her knee pain had gotten so bad from her arthritis, they may offer the procedure of getting a new knee to help her achieve her goal. But it's all in the context of, it's an intervention that's helping to achieve the goal, not for the sake of just treating the disease. I don't know if that helps clarify that point.
Thanks, Dr. Tinetti. I can see Gareth is thanking you in the chat. He's not able to unmute himself.
Okay, good.
Thank you for your response.
Good. That's a great question.
I want to circle back, Dr. Tinetti, and just kind of on the fringes of John's earlier question, and this idea of kind of, how often have you encountered times where patient priorities have either conflicted with kind of clinical recommendations, or there's been safety concerns, and how do you deal with that when those situations do arise?
So, so again, remember that the the priorities are primarily the outcomes people want, and a little bit their preferences, their physical preferences. But knowing the outcomes that people want, then if there is a intervention that, let's start with an intervention that they really don't want. So this is what happens is if you ask people, do you want this procedure? They'll say yes or no. But that's in isolation is like, well, you might ask me, well, do I want to take a plane? Depends where I want to go, right? So if you start by anchoring what's the outcomes that people want, they're realistic and actionable, then that conversation about the intervention isn't, oh, you don't want this procedure. It says, oh, you said what's most important to you is you want to be able to walk a mile. I don't think I can help you do that if we don't give you a new knee. So are you willing to do this if it gives you the outcome you want? So it's never against the guidelines or for the guidelines. Is that intervention going to help them get the outcome they want? And if that disease is what's impeding them getting the outcome that they want, then there's a trade-off, and that's the discussion then becomes the trade-off. If this is what you really want, are you willing to do this? And then it becomes a compromise and a discussion, as opposed to this, I either want it or I don't want it. So I think it frames that conversation. In terms of safety, I presume you're talking about somebody who wants to do something that give an example of what might be unsafe, that might be helpful.
I guess if it's like, I'm somewhat referring to, I feel like we live in a bit of an era of, WebMD. Everybody feels like they're the experts of their own care. They want a treatment or they want something that doesn't actually match with their. So, to what extent have you seen that there's a bit of a distortion of like people's expectations of outcomes based on our access to information and oftentimes the inaccuracy with the information that we have access to?
Yes, I mean that definitely does happen. It happens much more with actually pretty healthy people. At least in my experience, it's usually been the healthier end of the spectrum who finds something that they want because there's the new thing that's gonna get this a little bit better or that get a little bit better, and that's just a matter of just as something is that is having that conversation that I don't believe that what we know today, that would be something that would be potential helpful that I can offer to you, I think is the conversation. With older adults, again, as they start to accumulate sort of problems, and then it really becomes the matter of really getting to their getting to realistic goals. And once they get realistic goals, if there's something that they think is going to help that goal that I don't necessarily believe in, well, then again, that becomes a matter of sort of negotiations. But there comes a time when people who are capable are able to make the decisions that they want. It doesn't necessarily mean I have no obligation to offer someone an intervention that I really don't think is going to be beneficial. I don't think that's what this is about at all. Right. And knowing what their priorities are very often actually helps that discussion, because then you can move them to intervention that you do think really are, you get the focus off of the intervention and onto the outcome that they want and kind of move them around. But there's no obligation to offer any intervention that's not helpful. That being said, sometimes people want to be able to do things that I may not think are safe, because getting back to my fall problem is, gosh, I don't want to use this cane because it makes me feel old or whatever. I'm going to have that conversation about the trade-off. Is you said what's most important to you is want to be able to walk longer and safer. And I know you don't like this cane or this walker, but I do really think that it's going to help you achieve the goals that you want. But sometimes people want to do things that are unsafe, and if they're capable of doing it, they're good. I have no way to stop that.
Of course. So something that's been percolating as we've been talking is this idea of kind of like time. I think all of us have probably had the experience where you go in to see a doctor and you're in and out in 5 minutes and you barely had a chance to talk. So kind of what's the trade-off from your perspective around, understanding people's priorities takes time, and that's a short commodity often. So curious to know how that gets balanced
Yeah.
in your work.
It's not balanced. It's I wish I had the balance for it. It's probably the thorn in all of you ask any health professional, and they will tell you it's the thorn in their side. It is the number one cause, I think, of healthcare burnout. We're asked to do see more and more people with shorter time as their health problems are getting worse. And as the amount of things we can do to help them are getting better, but the conversations to really align those are getting more. It's getting worse and worse. And I don't have the answer to that, except for at some point, societies have got to make the decision that healthcare is a right, and it's not up to the insurance companies who are, at least in this country, making a lot of profit to allow them to be setting the time frame. So, but until that happens, and we're very cognizant of time, that part of what, first of all, we'll say is that this is not an event. This is not you go talk to your clinician and then it happens. This is a way to, over time, move the conversation from treating 10 diseases to treating you who has 10 diseases and a lot of other things. So one of the things that we have found is once you know people's priorities and you get comfortable with that kind of communication and decision making, it actually takes less time because you're not going through each of those 10 diseases. Is you focus here, people identify where they want to focus, and that's where you spend whatever precious moment you have at that time. And then you don't have to have as much discussion about everything else because, say, well, you said this was important to you, so I think we need to continue this medication. So you don't have to talk about everything. You can kind of sum it up quicker, and it actually is a little bit quicker. The time to identify their priorities does take time. And again, is that can be done in a lot of different ways. That's part of the reason why we created the My Health Priorities website, so the people who have access to the computers and the internet and feel relatively comfortable or have somebody who can help them walk through it, they can actually walk through it and actually bring it to their clinicians. And we've seen that happening more and more. So I think if I had to say the barrier that continues to exist is the time to identify people's priorities. And the initial concern on the part of health professionals that it's going to take them longer to have the conversations. And that's just a matter of them practicing, because it doesn't take longer. It actually is shorter over time to do it. But until I think there's going to be such a crisis in people really pushing back on how crazy it's been in healthcare. It's not helping patients and it's not helping health professionals. I don't have the answer to time, but I'll just say it doesn't take longer and it may take shorter over time.
Right. So there's a couple follow-up questions that have popped up in the chat, but I want to touch on a comment by Francis. She's talking, I mean, the problem in Canada is that many people don't have a GP or a family physician, and it seems somewhat dependent on kind of a relationship with your family physician. So how can older adults, if you don't have a family physician, or perhaps your your physician is not on the patient priority train yet, how can you kind of advocate as an older adult for yourself to get that kind of patient-centered, patient priority care? Is there anything that older adults can be doing proactively in their care to kind of get their doctor or if you walk into a clinic, even for that matter, get that?
Yeah. Well, I think the first thing to do is, ironically, as we were working with putting together this approach to identifying and acting on patients' priorities, and we decided where does it need to live? And in this country, as well as I think most countries, healthcare is still remains very fragmented. So even if you have a wonderful primary care clinician, that doesn't mean that your cardiologist or your social worker or your physical therapist is going to be on the same page. So as we talked more and more about it, we realized that the only common denominator was the individual himself or herself and her family and his family members. So the only way I think we're really going to change this is for individuals themselves to demand it. So patients have, I think and I learned this with my fall prevention as well, is it was really when older people started really demanding their clinicians worry about their falls, that it actually became part of practice. And I think the same is going to be true here. And I think patients have more power than they give themselves credit for. That's number one. So number two is a place to start is identifying for yourself what really matters to you. And again, that's one of the reasons why we did that the website myhealthpriorities.org. And I know I just saw pop up somebody asking for that to go in the chat. So I hope that you're able to actually put that the link to the website there. We do actually have at the end of that some mechanisms for people getting prepared and practicing talking with their clinicians. And one of the things that we have found, because we were faced with that even in our research, that actually people just going and knowing what they wanted changed the conversation, even if they didn't have a primary clinician, or if they didn't have a primary clinician that really understood or bought into this. And they can take it to all their clinicians. And it's not a perfect answer, but it is a way to get things started. And I think that if people feel comfortable knowing what matters, it's really hard when somebody says this is really very concretely and realistically, this is what they want. I will tell you, it is very hard to ignore that. And you're not going to get the answer you necessarily want at first, but people will almost invariably find that it really changes how the health professionals talk with you and make their decisions. And they are our most powerful tool as people themselves.
It seems like we are rapidly approaching the hour, and it seems like a great place to finish, Dr. Tinetti. I'm going to come back to you in just a moment for some kind of closing remarks, key takeaways you'd like our audience to leave with. But in the interim, Luana, while Dr. Tinetti gathers her thoughts, please join us next week. I know we touched briefly today on climate change, and I'm sure there's going to be some crossover in our next week's discussion with Dr. Pallavi Pant, who's going to be discussing the growing adverse impacts of air pollution on the global aging population. So stay tuned, and I'm sure we'll get to touch on many of the elements from today's discussion as well. But Dr. Tinetti, the floor is yours for kind of final remarks. What would you like to leave us with today?
Well, I have to do one call out to Paul, who put in the chat about being in the rural area up in Lake Superior. I was just there 2 weeks ago. It's my favorite place on earth. I don't know how he knew that, but so call out to you. So I think my take home here is that I hope that the reason I get up at 6:30 in the morning to do these calls is you're the people that are going to make this happen. I think if there's one thing that I leave you with is that I do think that the individual himself and herself is going to be the driver to this change happening. If everybody just keeps demanding this, it's going to be harder and harder to ignore it. And is just to know that we all do have our own health priorities, and we can be the driver to make that change happen.
Well, thank you so much, Dr. Tinetti. It's been such a fabulous discussion today. And to our Global Cafe audience, thank you as always for joining. We look forward to seeing you next week. Thank you so much, everybody. Have a great weekend.
Thank you. Thank you for having me.
Tinetti.